Well, hello, everyone, and welcome to another episode of You've Got the Power. I'm your host, Dr. Jason Deitch, and of course, we are here with Chief Medical Officer of the Centeno-Schultz Clinic in Broomfield, Colorado, Dr. Chris Centeno. Happy Monday to you.
Happy Monday, Jason.
We got a great topic for all of you. On Mondays, we have a large audience of you that are really focused on often the upper cervical part of the spine. Today's topic goes back to the upper cervical part of the spine, and we're asking the question, why is it so difficult to find medical professionals who do injections specifically in the upper cervical part of the spine, specifically C0-C1, C1, C2? Doc, we just started the conversation briefly. Let's bring everybody else in on it. Why is it so difficult to find medical providers that really address this unique specialty?
Yeah, Jason, I think you first have to understand who it is you're talking to, because you're going to get a different answer if you're talking to different types of doctors. And the first divide there would be if you're talking to an interventional spine specialist versus a prolotherapist. And they're quite different in their training. Interventional spine is a fellowship that you've got to take these days. And so that means you finish your regular training and then you go through an additional fellowship and you get advanced training in how to inject, for instance, in this case, spinal joints under x-ray guidance using contrast to make sure you're in the joint. Then on the other side of that fence, you've got prolotherapists. And prolotherapists, again, weekend course type training. There is no specific AGME approved training program that you can take there. AGME is the group that certifies doctors for postgraduate education. So you take this weekend course, you learn your prolotherapy. To the extent that you're using an x-ray machine, it's really just to kind of get into the general area. It is not at all to inject a specific joint. And 90% of the time, you're not using an x-ray machine anyway. So two very, very different things here. And it depends on who you're talking to. So if you're talking to the first kind, the guy that is trained to inject spinal joints, 98% of the time, they're going to say, no, thank you. We don't do that here. We don't go any higher than C2-3. We don't do C1-2. We don't do C0-C1. We'll talk about those reasons. If you're talking to the second type, they might say, sure, we'll inject those areas, but they're not talking about injecting the joint. And so many of those patients who have seen those prolotherapists are just surprised, even if they've had PRP done the prolotherapy way, they're incredibly surprised that they never got those joints injected. They thought they did. So depends on who you're talking to.
This is such an important topic. I'm glad you brought it up. I'm going to see if I can get a couple of the common nuances of this conversation. Because as you're a medical professional, chiropractor, I've worked with thousands of chiropractors over the years. Just as an example, they hear the word stem cells and they oftentimes have a different version or different understanding of what stem cells to be. And I just sort of bring out that it's very common, unfortunately, but it's reality as professionals to professionals that not everybody's on the same page with the words, the reasons, the understanding. Just so I understand what you say, and I want to make sure I'm repeating it accurately, roughly 98% of the time, the medical professional is going to say, yeah, we don't go there. We don't work with that upper area. That 2% roughly, if they aren't working with you at Centeno-Schultz, may say, sure, we work in that area, but what we're specifically talking about here is injecting the joints themselves. Let's break down what is the difference? Why is it so important? We'll get into the dangers. I know we want to talk about that as well. But let's just finish up. What's the difference between injecting the upper cervical area and really addressing and injecting the actual joint itself? Why is that important between those two differences?
Yeah, so let's start with the area. If you're injecting the area, that's more of a prolotherapy approach. Now, the problem, prolotherapists really shouldn't be injecting this part of the neck blind or even with guidance without contrast, because the problem is that there is the vertebral artery that goes through here, and that supplies blood to the back of the brain. If you're doing it in the joint with guidance and contrast, contrast is something you inject so you can see that where the stuff is going to go. That's a different story, because if you were to inadvertently inject the vertebral artery, which is close, then you would see it go into the vertebral artery. And in fact, those types of fluoro machines have a $20,000 or sometimes $30,000 package on them. That's a digital subtraction angiography package. So if you think it might be going into the artery, you can run a digital subtraction angiography loop to black out everything but what you're injecting on the screen. And it does an angiogram so that you can digitally see if you are in fact injecting into that artery or if it's just going into the joint, meaning it looks at only things that change on the image, which is going to be your contrast. Again, that's very different than a prolotherapist who is injecting prolotherapy solution or PRP, because if he gets in that vertebral artery, he doesn't have the ability to know that he's in the vertebral artery, because he's not injecting contrast, doesn't have that digital subtraction package on that type of fluoro machine. Wouldn't even work because there's no contrast. It only works with contrast. And injecting PRP into the posterior brain, hopefully there's no clots, but it's probably not going to be catastrophic. But if he's injecting prolotherapy solution into the posterior brain, that could be catastrophic. That could be at least an event where the patient loses consciousness and needs to be resuscitated with a full resuscitation for a couple hours until they wake up, and could be all the way up to brain damage, because you are injecting a substance that kills cells. That's how prolotherapy solution works. It kills local cells and then causes a brief inflammatory healing response, but you're injecting that into an artery that will go to the brain. Obviously, that's not good for brain cells, and so that could be a bad, really, really bad day for everybody. So just realize that, again, two completely different approaches here, and if you're going to be injecting the upper neck, you really got to have all of the tools, including the contrast, the education on how to inject the joint, the education to be able to identify if you have inadvertently placed the needle inside that vertebral artery, which is just not available in the standard prolotherapy world.
So let's break that down for people watching. There's a couple of specific things I just want to highlight. Number one, you're talking about what are you injecting? Are you injecting PRP, your own body's cells that accelerates healing? Or are you injecting a product, right? Something that comes from someone else, not yourself, right? Everyone, this is how you get your power back. It's these nuances that are the difference that make the difference. And even doctors, this is such a, I'll say, new field to many, not new field in existence, but new field to many professionals, that they often don't understand the nuances. They go stem cells or prolotherapy or yes, we're injecting the neck. It's too broad. So you want to understand, number one, what are they injecting? And then two, how are they injecting it? Just putting a needle in the area is completely different than under, I'll say, expensive and very important, necessary equipment to make sure, because there is the vertebral artery, the brain stem, it is so neurologically rich in this area, you got to make sure you get the right stuff in the right place. Is that a simple way of just making sure people are able to understand, I guess, when they're sort of shopping, looking, researching, you know, what are you putting in? How are you making sure it's getting to the right place? And if they say, well, we put it in the general area, that's a completely different conversation than we are specifically guiding the right stuff to go exactly in the joint area, because that's where the damage is and the healing needs to happen. Is that a simplified way of addressing what is a complex issue?
Yeah, so maybe a way to even take it more simply would be to say that the prolotherapy approach is like a shotgun approach, and the X-ray guided joint approach is more like a sharpshooter approach. And then realize that It's still possible to shoot into the wrong area if you've got a shotgun. In fact, you're more likely than not to do so. But if you've got a sharpshooter approach with a scope on it, it's unlikely that you're going to shoot into the wrong area. So that's maybe a super simple way to look at it.
Phenomenal way of thinking about it. Yeah, you can't afford the collateral shots to go to other places in your metaphor. You got to get the right thing in the right place because it is so sensitive and neurologically rich. It's your brain. It's your brain stem. It's your vascular to your blood, blood to your brain, etc. So super important. We're getting a lot of questions. So Doc, let's hit to those and start with what was submitted in advance by Glenn Benton, who asks, if my doctor says he wants to do this, how can I tell if he has the training to do this? It's awfully close to my brain. That's a great question.
Yeah, this is a hard one because, think about complex things that you do in your life or that you've learned how to do. Let's say you've learned a very specific, difficult, or kind of hard to learn skill. If you've done whatever that activity is a dozen times or 24 times, you're not really that good at it. If you've done it 100 times, you're better at it. And if you've done it 1,000 times, you're an expert at it. So it's the same thing here. If you've got a doctor that's done this a dozen or 24 times, they're still learning how to refine their technique. If you've got a doctor that's done it 100 times, they're getting pretty good at it. They've washed out most of the issues of their technique, but they may not have seen yet all the different anatomical variants that can happen, because realize for us doctors, that's a big deal, right? If we're injecting this C0-C1 area and this upper cervical spine and these facet joints, there are patients who really aren't built like other patients. And that's not something your average mechanic deals with very often, because the cars are all the same, but we humans have subtle differences between us. So that's, I think, the biggest thing you need to do is to ask your doctor the question, how many C0-C1 and C1-C2 joints have you injected? And find out for each one of those if they've done it, and I'd even ask them, how many times do you do it a year? Because maybe that's easier for them to remember. So in the last 12 months, how many times has this doctor injected C0-C1? And if the answer is, well, he's asked to do it about 10 times a year, then I think you've got a problem, meaning that you're not going to be really good at something you only do 10 times a year. But if the doctor says, oh, I've done it 100 times this year, then that's a totally different story, right? Because we've done 100 times this year. Over the last 10 years, he's probably done 1,000, assuming he's got a little gray hair. So those are the kind of questions I think you need to ask. But that's a critical issue, is you need to make sure that the doctor has done this enough times where they are competent, and doctors aren't any better at learning things more quickly than you are. This is different stuff, and they have to have different education to get there. But think of a skill again that you learned and you got good at, playing the guitar. If you play the guitar, the first dozen times you do it, you're not going to be very good. It takes a while before you get really good.
Great points, super important. As consumers of healthcare, and that is the term, the idea is not that you just sort of follow the pathway that your insurance company has set for you. I assure you their agenda, their priorities are not your health as their top priority. But unfortunately, many people behave that way. They go, well, that's what my insurance covers. I should go to the doctor that's on my insurance. That is a different agenda than, how do I find the best doctor who is the most skilled to do the procedure I need that's going to be to my best benefit and ultimately get me healing faster and better than the cheaper option. So if you're watching, these are the ways you make good decisions when it comes to healthcare. Not necessarily your budget, because people are very guilty of making great, I'll say, mistakes in the long term, thinking they're saving a lot in the short term. And when it comes to healthcare, when it comes to these types of procedures, you want to make sure you get it right the first time. So this is how you do it. Let's take some questions from our friend Damien, regular viewer. Hey, Damien, he's got a couple here. I'll read them off. He says, good morning, good afternoon to you as well. Number one, who are your top 3 competitors in the field of orthobiologic and regenerative medicine? And a second question I'll just throw out to you is, can you do an overview on the 10X machine during your Facebook Live or general video? Thank you in advance. How do you want to take those, Doc?
Yeah, that's a good question. Top 3 competitors. I'm assuming he's asking well, I guess he could be asking for Regenix. He could be asking for Centeno-Schultz, since we're on the Centeno-Schultz page. So let's get that question answered, because the answers are obviously going to be different there by Damien. And then on the 10X, we can certainly do one of these on 10X. That actually might be a good one to do this Friday. We can start advertising it now on the concept of just bone spurs and getting rid of bone spurs using a needle, which would be one way to do that, would be that 10X machine. And just the overall idea of what bone spurs are, when they're beneficial and shouldn't be removed, and when they should be removed. So let's add that to the docket for this Friday when we're on the Regenix page.
Excellent. So Damien, please join us Friday. We'll thank you for your request. We do take requests, so thanks for that. His comment just on the first question was basically in the field of orthobiologic and regenerative medicine. So he doesn't clarify whether it's specifically Centeno-Schultz Regenix, but generally speaking, I guess I'll ask it maybe a slightly different way, which is there anybody else that does what you do? I know these words are thrown around, stem cells, PRP, but who else really specializes in what you specialize? And, is there any, quote, competition?
Yeah, listen, there are, on the clinic side, let's go there first. There are certainly clinics that I would refer a family member or a friend to that I've got on my list. Now, is there anybody that has, a 2,000 square foot CGMP class clean room in their practice in the United States? No, doesn't exist. There's no one else out there that has that right now as part of a clinical practice doing orthobiologics. Is there anyone else that has $1 million research lab as part of their practice where they can do this research? Nope, nobody has that. Closest you might come to that, what used to be the Stedman Hawkins Clinic, now Stedman Clinic, maybe Stedman Philippon, it changes that name, it changes its name all the time, has gotten a better research program for orthobiologics and started to add some lab stuff in there. So I think they are starting to get engaged, but their focus is surgical orthobiologics, not non-surgical. So maybe that's kind of in there. Andrews is trying to do the same thing. But again, that's surgical, not non-surgical, meaning that if the doctor at Andrews tried to do the ACL procedure that we do, he wouldn't be there long, because that competes with the surgeons who run the show there. So again, the answer is, not there. But as far as people that do quality orthobiologics and are trying hard to do this right, I definitely have a short list of clinics I would refer to, because I know the doctors, I know what they're trying to do, know they don't have all the facilities that we have, they don't publish the research that we publish, but they're good doctors.
That is hopefully helpful, Damien. It's difficult because when I hear the question and just knowing what I know, I don't think of any of them as competitors. I actually think of them as confusers. And it's because it is in these nuanced conversations that you get to know what it is that you really need and what it is that you're really getting. And between the training, the technology, the research, the experience, it doesn't seem like there's really any groups or brands out there that is even in this, I'll say, playing field. They use words, they confuse, they sort of muddy up the conversation in the market from my perspective. But it's hard to say, yes, anybody competes with. It'd be like saying what competes with Rolls-Royce. Sure, there's other nice cars, they mean well, they they're good transportation, but when you're the top of your field, I'm not sure we call them competitors. Does that sound right to you, Doc?
Yeah, again, like I said, I know some good doctors out there. They don't do all that we do, but they're good doctors. And so, listen, ask me anytime about a specific area, and I can usually find someone, a good doctor that's trying hard to do this stuff right.
Excellent, excellent. Thank you for your question. All right, let's move on to Adrienne Couillon Barnhill, regular viewer. Thank you for watching. She asks, first question. With traditional PICL, I had excellent filling at the alar accessory and transverse ligaments. Does this mean that I would not need the above PICL approach? I'll move on. The second question is, or could my symptoms dictate that I specifically need my upper alar ligaments treated despite a successful under approach? How can you tell if the upper alars need treated?
Yeah, so this is a really good question. What it teases out is that there's an upper alar ligament injection approach and a lower alar ligament injection approach. Well, and let's call it alar transverse, accessory, SAAOL. I mean, lots of different ligaments in there. So let's say above atlas and below atlas. What we're talking about is that the below atlas technique seemed to be very successful in getting stem cells into things like the transverse ligament, the accessory ligament, and the alar ligaments, which go up like this. The question is whether or not, if that's the case, the patient might also need an above the atlas technique where we can more directly inject the upper portions of the alar ligaments and then some other ligaments above the atlas. And the answer is going to be, it depends on the symptoms. We have lots of patients that we treated before we started doing the above atlas approach that did quite well. It was only really after we figured out how to do the above atlas and became very confident in it that we started trying to do it. And there are times where we can't really get below as well as we want, and we'll just go above. That happened last week in one patient because of this patient's, the way this patient was built and some of the limitations we had in flexing and extending that person's neck. It was impossible really to get below the atlas, so we just went above for the first time. So the answer is it's really determined by symptoms. If you're doing well symptomatically, if you're making progress, then there may be no reason to go above the atlas. We'll just stay below.
Excellent. Thank you for your question, Adrian. All right. Bia Shira asks, do you track results of the PICL in patients with EDS as its own group when collecting/analyzing your research data?
We do, and I just actually looked at that information. So for the last year or so, we've been segregating that out as a group, and I just got that information back from our research team. And one concern is that we don't really have enough 12-month data yet to make a go of it. And really delineate those two groups. Now, so far, I'm not seeing a difference in outcomes between those two groups, EDS versus non-EDS, but I'm going to really wait on that till we get some more 12-month data in there. I was going to actually respond to them later this afternoon that there may be a way to goose those numbers up at 12 months so that we get a better idea of how people are doing at least a year out from the first procedure. In those two groups. So yes, we do, and we have been looking at it, but we're trying to make sure that we can get more information going there, and hopefully we'll be able to do that pretty quickly.
Excellent. Thank you for your question. Adrian follows up with a second question, asking if a note says, quote, excellent filling at, end quote, a ligament, does that describe leakage toward and around a ligament, or is that ligament being directly injected? The trauma of the injection itself is important for kickstarting the healing, right?
Yeah, so generally what that means is we would call it flow of contrast in a certain ligament. So one of the things that's important to recognize is many of these ligaments are kind of bleed into the others. So we all would like to say this one's the transverse, or I'm sorry, this one's the transverse, this one's the alar, this one's the accessory. But really, the body isn't organized that way. We like to organize it that way for our brains because it's easier for our brains to conceptualize. But the body is organized as kind of, these things being almost one unit with fibers that go different directions. And so what that means is that the contrast went, for instance, in the transverse ligament or the accessory or the alar. So that all means that we were able to get stem cells in whatever area was described.
Okay. The trauma, excellent. So just for clarity, the trauma, is there anything, I guess, if you've got follow-ups on that, Adrian, I just want to make sure we're answering your question.
Yeah, I mean, the needle trauma really isn't the big deal here. The trauma is injecting something into these ligaments that's pro-inflammatory, like bone marrow concentrate. So as long as we got flow of the cells in those areas, I think we're fine there, meaning that we're not going to get a lot of extra, other than that, a lot of extra risk if we just like keep poking at the ligament, that kind of thing.
Perfect. Hopefully that clarifies. We're here, Adrian, if you got other questions. Let's keep moving on with Livia Benkova. All right, here we go. Hi, I'm getting my treatment in Broomfield soon for CCI. I wanted to clarify 2 questions just due to my personal concern. I do believe that the PICL helps, just wanted to know how high the possibility is that a patient could get worse after the PICL than he or she was prior to the treatment. If there would be some new symptoms brought on by the procedures, these would be temporary, right? My second question, do EDS patients react to the treatment as good as other patients? Thank you.
Yeah, so I think we just answered that one about EDS patients. The answer is that we are looking at that right now, and we hopefully will have that data soon. We're trying to get more outcome endpoints at 1 year to make sure that I can give you an accurate answer that's statistically significant. When it comes to flare-ups, I don't know of a patient at this point that had a permanent flare-up due to the PICL procedure. Having said that, it's incredibly important to note that any injection-based procedure or surgery can cause a permanent flare-up in any patient. So I can't rule that out 100% that we might not see one tomorrow or the next day. So you need to realize that there's always a small probability that that could occur, but let's say the probability is probably less than 1 in 400. So that's the best I can tell you there. We have seen some pretty substantial increases in symptoms, and that tends to be directly related to the type of patient that we're injecting, and also directly related to how much time there is between procedures. Usually if there's 4 to 6 months between procedures, people, even if they're having a bad time with a flare-up, will flare up over the first couple weeks to a couple months and then come down the other side. But always important to realize that there's no guarantees with anything any doctor does to you, whether that's giving you a Motrin pill. As an example, the fatality rate from taking Motrin for more than 60 days is 1 in 1,200. So 1 in 1,200 people that go to the grocery store, buy Motrin, take it every day for 60 days, will die of a GI bleed due to the Motrin. So you just need to realize that, that's the nature of medicine. Same thing with chiropractic adjustments. No guarantees there. It's a very low risk technique. But we've certainly seen patients who have had upper cervical injuries with chiropractic adjustments that perhaps weren't done with the highest skill levels.
And it's all, I think, when speaking risk, I believe it should usually be spoken in the context of relative risk. And typically, correct me if I'm wrong, one of the most dangerous things we all do is just drive to the office, which oftentimes statistically may be the most dangerous thing most of us do in our day. We don't think twice about it in most cases. So it's all relative risk from there. All right, thank you for your question. You're okay on time? We got more questions, just making sure?
Yeah.
Great.
doctor.
Patricia Taylor asks, is a standing MRI, perhaps with flexion and extension, a good, quote, screening level test for CCI? Or is there something about viewing the motion of the upper C spine needed to comfortably rule out significant CCI? Thank you.
Yeah, so you could get a standing flexion extension x-ray. So that might give us, for instance, information about how much motion there are between the vertebra as they slide and you flex and extend. The hard part to replicate is an open mouth view with lateral bending, which is what's part of a DMX and some of the other movement-based things. What's different about a DMX is a DMX allows you to move a certain direction as you would naturally stop and then go back the other way. And you don't really get that on static films. So DMX does add another dimension in looking for instability. And there may be ways to try to replicate it without that motion or that active motion. Just realize you're going to struggle to find anyone that knows how to do those types of things with any accuracy outside of a DMX site.
Yeah, just having pictures are not the same as motion pictures. And so it's essential to know the difference. I love the questions because it is in these nuances that makes all the difference in the world. So, you appropriately asked not just an MRI, a standing MRI. Gravity matters, motion matters, all these details matter. So great questions. Keep them coming. Thank you. All right. Ive Cruz asks, are treatments with stem cells less effective the older you get? Great question.
No, yeah, that's not something we have seen. So listen, we've got the world's largest stem cell treatment registry for orthopedic conditions. There's no one who's even a far distant second, meaning that we've been looking at patients and monitoring their results now going on 16 years. And we don't see age effects in most things. So what I mean by that is, for instance, knee osteoarthritis, there isn't an age effect. Ankle osteoarthritis, shoulder osteoarthritis, no age effects. The types of procedures we're talking about today, we haven't seen age effects. So just realize that that the only thing we have seen age effects in, and using the patient's own stem cells, is hip osteoarthritis. But a lot of that probably has to do with older people tend to have more severe hip osteoarthritis. So that's one of the few areas where we do see an age effect. But a lot of that has to do with the severity and the fact that the joint will collapse as you get older. So just realize at the end of the day, we're not seeing substantial age effects, and that's more of a sales tool for people that are selling fake umbilical cord and fake amniotic stem cells that aren't real. There are no stem cells in any of those products. And we've been doing this longer than anyone else on Earth and tracking this type of data longer than anyone else on Earth. And we don't see that.
I want to make sure people heard a very important nuance in what you said that really, I think, relates to people, and that is understanding the impact age has. Age doesn't affect the quality of your stem cells in your procedure, which is the original question, but age and allowing an injury to age over time will make you worse and will make it more difficult for you over time to get the results you want. Those are two different questions, but it's essential. It's sort of the same spirit. The longer you wait, if you have a condition, these are all progressive conditions. Even though the pain may come and go, the underlying problem persists. It's one of the most difficult parts of, I'll say, our job as doctors is to help people understand the distinction between pain being the problem and pain being a symptom of an underlying problem. And the goal is not just to get rid of the pain, as foolish as that may sound to many of you. The goal is to correct the cause of the problem so the symptom naturally goes away because it doesn't need to be there. So when you ask about age, that the important part is get yourself checked sooner rather than later. Don't allow the condition to progress over time. That's going to be your safest bet and choice. Comments on that, Doc, or shall we go to another question?
No, yeah, let's go to another question.
Right on. I'm not sure how to say this. Ivo Ney asks, since mast cells could be diagnosed through a bone marrow biopsy, is it okay to do stem cell treatments if you do have MCAS and make you sicker regarding both spine stability and MCAS?
Yeah, we haven't seen any issues with MCAS type patients. And so realize that taking bone marrow cells and moving them from one place to another isn't going to change anything about mast cell disease, meaning that if you get a fracture, as an example, as an MCAS patient, the bone marrow bleeds into the fracture line and fills that gap, and that's how the fracture heals. So there is really no problem with moving bone marrow from one place to another in MCAS patients or any other patient that's got some sort of issue like that. So no, I don't see that as an issue, nor have we observed it.
Great question. Thank you for asking. Let's keep it going. Roger Chin, regular viewer. Thanks for tuning in, Roger. He asks, I had a 90 milliliter bone marrow draw for my PICL number 2, but only had 54% of the TNCs as before. He says 989 M down to 537 M. 6 months between PICLs. I had HBOT before PICL number 1, but not PICL number 2. With fewer TNCs between 2 injections, above and below C1, how will that affect my outcome? Does ME/CFS affect stem cell recovery?
We don't really have any information on ME/CFS and how it would impact stem cell recovery. The only stem cell issue we've noticed when we're going into the same site on a repeated basis once every 6 months is in women who are over 50 years of age. That can be a problem. So now we will change the stem cell draw type. So we'll do type A for the first one and type B for the second one to try to reduce the risk of that kind of issue happening. For everyone else, those numbers bounce around quite a bit. Realize those are not stem cell numbers, but total nucleated cell numbers. And they relate generally to the number of stem cells in the sample, but that's only for research purposes over a large group, not individual counts. So for instance, the stem cell content of those two may have been identical, even though the TNCC numbers were different.
All righty. Thank you, Roger. Thanks for the question, and thanks for being a regular viewer. Diane McCracken asks, may I please ask if the results of PICL and or posterior stem cells can be affected by sneezing, coughing, laughing, etc., given that this moves or impacts the whole upper cervical region?
No, I wouldn't think that there's any issues there with coughing, laughing, etc. I mean, you've got to move, you've got to live your life. And if we put you into any type of immobilization, it's going to be, we'll pick up a little bit on keeping things still, but we'll lose an immense amount on muscular stability. And that, for every month you're in a collar like that, it's going to take 6 months of getting that muscle back. So losing it is quick, recovering it is hard.
There we go. All righty. She goes on to say, may I also thank you for what you are doing? I'll answer that one. Yes, you can. We appreciate it. All right, let's keep going. Megan May, also regular viewer. Thanks for watching. She asks, do you know anything about lymph nodes? Yes, we do. I believe my traction injury and CCI affected the ones on my head. Curious if they can heal.
Yeah, that's a little out of my area of expertise. It's certainly possible to affect lymph channels, and so something that you might consider if that's I mean, for instance, if you've got a lymph node or a lymph channel problem, you would tend to see swelling in that area or localized swelling in that area. And so it's possible to disrupt those. Normally just PRP injection of the soft tissue can help rebuild those in vascular channels as well.
All righty. Thank you, Megan, for your question. And this is our last question I got here. So last call. Jenny Abbott Edwards asks, if someone has an instability in the cervical spine, C3-C4, C4-C5, and degenerative disc disease, C5-C6, what would the course of treatment most likely be? Prolo, PRP, or stem cell? Once the disc has collapsed, is it too late?
No, it's not too late. We treat patients like that all the time, including me. So no, not too late at all, meaning that we can treat patients who have collapsed discs in their neck. We treat the ligaments and the degenerative disc disease. We'll treat the joints, nerves if needed, etc. So not a problem to have collapsed discs.
Outstanding. Those are all our questions for today. Today's program is all about asking the question, why is it so hard to find medical professionals that understand how to effectively inject the upper cervical spine? Occiput, C1, C2. Doc, let's wrap up the show for today.
Yeah, again, as I said, the biggest issue that you have to deal with is just understanding that these joints can be difficult to inject, and it's even more difficult to find people who have done them a lot. So just be careful there and trying to find someone injecting those joints, making sure that they've done 50 to 100 a year, not 10. And also realizing that if you're talking to prolotherapists, you're getting a totally different point of view because they're not trained how to inject the joints inside the joint. They're just going to kind of put it in that area, and injecting into that area without using contrast is never a good idea because there's an important artery that lives there.
All righty. We got one last question, probably a good one. Can you recommend someone in Europe?
To do what?
That's a good question. They didn't include that. So let's assume it has something to do with CCI upper cervical care.
Yeah, there's no one I would recommend in Europe that I know of to do the PICL procedure. When it comes to injecting the upper cervical spine, we do have a site in London that has experienced physicians who have done a reasonable number of those injections. So that's something that you might want to consider. But just realize that interventional pain in Europe is a bit behind interventional pain in the United States. So there are fewer people in Europe doing those procedures at a high level than there are in the United States, probably by a factor of 10.
Very, very important. Thank you, Adina, for your question. Let's wrap it up. If you are wondering whether you have coverage for any of the procedures we're talking about here today, you want to go to the website regenxcoverage.com. That's regenxcoverage.com. And if you've got questions about your personal condition, you, a family member, a friend, a coworker, a colleague, somebody in a Facebook group, whoever it may be, your best solution to finding out questions about your specific condition is to either get on a telehealth conference with one of the doctors at Centeno-Schultz, either Dr. Centeno or Dr. Schultz most likely, or make it into the practice and really have an expert, the world's foremost experts who literally invented this procedure, find out what's going on with you. What's your condition? Is it, are you able to get help? Is it too early? Is it too late? Only one way to find out, and that's to actually ask one of the doctors about your unique specific condition. regenxcoverage.com to find out if you've got coverage, or reach out to us either on the Facebook page or on our website in order to be able to schedule your upcoming either telehealth or in-person appointment. Roger Chin says thank you, and with that, we say thank you. Thanks for joining us here. Of course, we're here Mondays on the Centeno-Schultz page. Friday, we'll be talking all about the machine that was brought up earlier, the 10X machine. We'll see you on the Regenx page on Friday. Thank you, everyone, for watching. Have a great week. Until then, stay well and be kind.